I'm Mike Morland, and welcome to Where Health Happens, a podcast from the Eugene Applebaum College of Pharmacy and Health Sciences at Wayne State University. On college campuses across the country, researchers are tackling some of the biggest health challenges facing our communities, from antimicrobial resistance and chronic disease to mental and brain health. This work focuses not just on discovery, but on turning research into better care and healthier communities. Today's guest is Dr. Christine Rabinak, Associate Dean of Research and Professor at the Eugene Applebaum College of Pharmacy and Health Sciences at Wayne State University. A neuroscientist, her research focuses on how the brain learns and recovers from fear, with the goal of improving treatment for trauma-related conditions such as PTSD. Her work is helping researchers better understand conditions like PTSD and explore new approaches that may improve treatment for people living with the effects of trauma. In this episode, we'll talk about the research priorities emerging across the college, how this work is translating into real-world progress, and the personal journey that led Dr. Rabinak to study the neuroscience of trauma. Christine, thank you for joining me today.
Thank you, Mike. I'm happy to be here.
So you and I have had the privilege to work together for a little bit over the last year, but for those who don't know you, talk a little bit about your role at Wayne State and your background and kind of what led you to this work.
Sure. Thank you. So as you mentioned, my research is very interested in understanding how the brain processes fear and how that fear can turn into pathological mental health conditions like post-traumatic stress disorder. Trauma, when it occurs, can either leave the brain stuck in this constant state of high alert, which is seen in conditions like post-traumatic stress disorder, or you can recover from that over time. And we're interested in understanding why it is that some people can recover after a traumatic experience and why others have more difficulty with that. And we're also, more importantly, interested in how treatments can help the brain relearn that it's safe.
So for me, some of the things you're talking about in my own personal experience has led me to think about this more deeply. Without going too deep into it, years ago, I dealt with a personal experience where both my mother and mother-in-law were dealing with terminal cancer simultaneously. And so my wife and I were both dealing with the pressure of care for them as well as for ourselves, and seeing the impact it's had on both of us, both immediately after and long term, has really made me think more about those experiences. And I guess from somebody who studied this, how does kind of that, even though that cancer experience wasn't ours personally, we experienced it adjacent. So how would you talk to individuals who have experienced situations like ours? Like, how is PTSD similar or different to people who experience these types of things adjacently?
That's a great question. So one of the criterion for meeting a diagnosis of PTSD is having a traumatic experience. But that experience doesn't have to happen directly to you. It could be something that you witness. And it also has to typically include things that are actual or perceived threat or harm to yourself or somebody else. And that's the first criterion to meeting a diagnosis of PTSD. And then we go from there and look at different symptom clusters. Regardless if it happens to you or it's something you witness, if it has an impact on you, it's valid. That's valid.
Okay.
And there really isn't a difference if it was your experience or somebody else's experience that was close to you that you witnessed. PTSD will develop very similarly. We don't categorize those as two different conditions.
When people experience PTSD, is that something that is immediate or is that something that can be delayed? And if so, do those experiences usually manifest as physical, mental, or could they be both?
Yeah, great question. So typically when somebody experiences a trauma or something bad happened to them, we typically all have an acute stress response, right? That's a normal kind of natural reaction. Typically over time, though, within months, that response starts to that heightened fear, heightened anxiety starts to dissipate. We're able to control it when there's cues or reminders of that traumatic event. We can start to suppress the anxiety that it causes. But in the case of PTSD, it's when that fear becomes so strong that it's almost impossible for that person to try to suppress those feelings. It's both mental and physical effect. So it's about the way you think about the trauma and you process it, and the way you think about if there's threat actually around you, so the cues that are around you. But it's also the physiological responses people feel, the anxiety, the hypervigilance, the all of that panic and everything. And that can be really hard for people to manage. And so one of the goals with PTSD treatment isn't to get rid of those responses completely.
Right.
Because it is good to have that. It's a safe.
I mean, we're hardwired that way. So
Exactly. Exactly. But one of the major goals of behavioral therapies for PTSD is retraining our brain on how to process and realize when threat really isn't present, and be able to suppress that and control that and not let it take over and interfere with daily functioning.
So what would you say in regards to how people respond with symptoms? Like what would be generally considered as a PTSD response from a symptom standpoint versus somebody who may just be feeling stress or anxiety from a situation? Because I would imagine there's probably some similarities, but there's probably also some criteria where this would definitely be seen as more PTSD, where this might just be, hey, you're struggling, but it doesn't quite fall under this criteria.
Yeah, great question. So with any psychiatric diagnosis, it really depends. One of the common themes or threads through them is that it impairs your daily functioning, your social functioning, your work-life balance, personal relationships. And it's really a combination of not just the symptoms a patient experiences or reports feeling, but it's also that they perceive that it's actually interfering with their life and what they'd like to do. So it's not the clinician saying, you have PTSD.
Right.
It's you describing and saying something's not right.
Right.
And describing it. And what the clinicians do is they have a series of tools that help them assess symptom severity and frequency. And that's really what we look at with PTSD. We've got some different symptom clusters. And diagnostically, you need to meet certain criteria, the number of symptoms in that cluster, the severity, the frequency of that.
Right.
So even if somebody doesn't clinically, diagnostically meet criteria, that's just a diagnostic. It doesn't mean that what they're experiencing isn't valid or that they're not suffering from the effects of a traumatic event. It's just it might not meet the diagnostic criteria by the book.
Right.
Right. And what's interesting about PTSD is it is so variable in how it presents in individuals. There's a really great paper that was published years ago, and it, in the title it says, there are over 10,000 ways you can be diagnosed with PTSD.
Wow.
Which makes it very difficult to treat.
Yeah. So in regards to treatment, obviously there's medications people can take, there's therapy. For I think a number of years, and probably more recently, we've seen a pivot in people's broader acceptance and less stigma and shame around mental health and getting treatment and seeing a therapist. How important is that aspect as well as the medication? Because obviously there's certain things from a neurological standpoint that medications can help, but where does that piece of counseling and speaking to somebody about the PTSD they're experiencing that really can amplify the effects of the medicine, or maybe somebody doesn't need necessarily to be medicated, but they really need to talk something out? Like, how does that piece into that larger puzzle?
Yeah. So medications typically treat the physiological symptom, but they don't change the way the person's thinking about the event.
Right.
So there's a couple different ways you can think about this. You can have somebody who understands that the environment they're in is not threatening, they're safe, but these cues in their environment are triggering this reaction.
Right.
And so cognitively, they understand that it's safe, but they might need medication to help kind of suppress the physiological response. And with medication alone, that might be sufficient. There might be individuals that don't really have strong physiological reactions, but are struggling with the cognitive processing.
Right.
And so that's where a lot of the behavioral therapies and cognitive processing comes into play.
Right.
It's more likely
Right.
you have a combination of
Right.
that. And so what's unique about PTSD is, yes, there are FDA approved medications. They're very limited, primarily antidepressants, and their efficacy compared to other psychiatric conditions like anxiety disorders is much less. So they're not nearly as effective. We're talking like 30% effective in patients. And they come with a whole host of side effects.
Right.
Right. And a lot of those side effects aren't worth taking it for the patient.
The trade-off isn't there.
Right. We have amazing behavioral therapies. The gold standard therapy is called prolonged exposure therapy.
Okay.
And what that involves is having the patient kind of revisit their traumatic event over and over again in detail, coming up with a fear hierarchy of things that in their life they might avoid or not do because it triggers a response, or things that are difficult for them. And slowly working on exposing themselves to those things and working up that fear hierarchy.
Okay.
And so that's homework that they do outside, and they listen to their trauma outside. But if you imagine somebody that's experienced something very traumatic, even talking about it and thinking about it in detail as if it were happening again can be very difficult.
Right.
But when patients do engage in the treatment and they complete the treatment, they can benefit significantly from it, which is fantastic, right? It's like night and day from when they start to when they finish. But if somebody doesn't feel like they've really received any sort of benefit after that first time of going through these imaginal exposures, the chance of them coming back it kind of drops, right?
Yeah.
So you might see discontinuation rates increase. So we know that the therapy works really well because of the associative learning processes underlining it.
Right.
But people, might bail early before they can receive that benefit. There might even be people that go through it and they still don't really receive maximal benefit. And we don't really know why. And even in those that do respond, it tends to sometimes be an incomplete treatment response.
Okay.
So to be considered response, it's typically a 50% reduction in their symptom severity score from a clinician assessment.
Is there a certain time period that progress should be seen, or is it just kind of as long as the person gets there?
Yeah, as long as the person gets there.
Okay.
It varies. Some people can see, so typically prolonged exposure can happen over, the typical protocol is 10 to 12 sessions. And so some people will respond after the first 4 imaginal exposures. Some need that full 10 to 12 sessions. And so it varies on response rates. Yeah, so even if somebody responds to treatment, they have a 50% reduction in symptoms. If they were high to begin with, their score could still meet the threshold for PTSD. So they haven't achieved subclinical outcomes yet.
Right.
And so that's the piece that we're really interested in our lab is we've got a therapy, a behavioral therapy that works, that targets the cognitive, helps with the physiological response, but it almost needs like a boost.
Right.
Because it's incomplete.
So we'll pivot to that in just a second. I mean, this is a great topic, obviously, and we could probably spend the entire episode talking about it. I did have one question that I think a lot of people might have, and that's regards to shared experiences, but different responses. So you're talking, we've talked a little bit about how people respond to situations. When there are situations where a group of people, for example, experience a tragic event, what is it about the difference in responses where some people may need therapy long-term and other people, it seems like it just doesn't affect? What is it about that differs from person to person? Is it just the uniqueness of being a person, or is there something biologically different in some people that respond to trauma differently?
Yeah, so I would say it's a little bit of both, right?
Okay.
So their biology might be unique to that individual, right? And so, yes, like you said, perfect example of people being a large group of people like the World Trade Center.
Right.
Right. So some individuals go on to develop PTSD and others do not.
Right.
And why that happens is one of the areas that researchers are exploring. And
Right.
so there are ideas in that there could be genetic factors in play and also just biology. And so what's kind of tough with PTSD is it's hard to know if the changes we see in like biology in somebody with PTSD and those that don't have PTSD is something that's a result of developing PTSD or if it was potentially a difference that existed pre-trauma that made them more increase their risk to developing it. And what's kind of hard about that and really answering that question is how do you design a study where you get a bunch of people who've never experienced anything bad and you assess them, you collect different measures, biological measures, you cross your fingers and hope.
Exactly.
Right. Hope a trauma happens to them and then see if they develop it or not. And so usually a diagnosis also of PTSD isn't something that happens immediately. I said there's that acute stress response. So usually there's a duration of time that if these symptoms are still occurring 3 months after the trauma, then we're entering pathology. But also it can take years and decades. And why that happens, not totally clear. A lot of it could be that some people describe avoiding things. They don't see it as interfering with their life. When you ask them, are you able to go back to your hometown if something bad happens? And they're like, oh, no, but it's not a big deal. But so,
but it's impeding you from doing something that it shouldn't. Right.
Exactly. So it all kind of just depends on the person. Which makes it tricky.
So I know we started off a little heavy on this. I want to back us up a little bit. Obviously, this is an area you're very passionate about. You have a lot of knowledge. Looking back to kind of earlier in your life, high school age, early college, is this the field you imagine yourself being in? Like, how did you get to this point? Or was this kind of one of those things where you were like, hey, I'm going to school to be a teacher and you know what, this isn't for me and now I'm going to do this? Like, kind of what's your journey to this point?
Yeah. So when I was a senior in high school, there was a new psychology class offered. So actually, the high school I went to opened my sophomore year. And so I was part of the first graduating class. And so I was also part of the first class that had this psychology curriculum. And I thought it was absolutely fascinating. And my teacher encouraged me to take the AP exam. Right. It wasn't an AP course at the time, but encouraged me to take it. And I did. And I got a really great score on that transferred over into undergrad. And so I didn't have to take elementary psych. So my very first class, first semester freshman year was brain and behavior and cognition.
Very light for a freshman, right?
Yes. And I had an absolutely amazing professor who I still talk to this day.
Oh, wow.
Yeah. So I went to the University of Iowa and it was Mark Blumberg. And he was just so engaging and very passionate about the biology of psychology. And I never really knew that this was an aspect of it. I liked science. I liked biology. I liked psychology. And this was like the marrying of my passions, right? And so this was really what I would say now we call neuroscience. At the time, it wasn't called that. But that class alone set me on this trajectory of wanting to understand mechanisms of psychiatric conditions. I hadn't been tied or, really focused on one condition over another. But then I saw a flyer in the psychology building. It was hand-drawn, looking for a research assistant. And I called the number and spoke to the postdoc in the lab, Dan. And he was my first mentor. In a psychology lab, I worked with Dan Nicholson, who was under the mentorship of John Freeman. And I still talk with John to this day. Unfortunately, Dan passed recently. But they were instrumental in me wanting to continue doing research. I started in that lab and I didn't leave until I started grad school.
Okay.
I worked year round and really started getting my first experience with the brain and behavior and understanding things that would then lead me to PTSD.
So what drew you to Wayne State specifically to continue this work after college?
Yeah. So if I can back up just
Sure.
slightly.
Yeah.
Okay. So when I first started working in research and I was looking at associative learning, I was studying this in rodent models.
Okay.
And so all through undergrad, we utilized rodent models to understand how animals form associations between what would be neutral, benign cues in their environment and then meaningful experiences. And then as a graduate student, I wanted to continue that. That's when I joined a lab that focused in fear learning and memory.
Okay.
And so I really continued to enjoy working in there, exploring the neural circuitry, being able to directly manipulate neurons and see how that changes the behavioral outcomes and memories. But one thing that really, not bothered me, but kind of just stuck in the back of my mind was, anytime we wrote a paper or a grant or you'd read a basic science paper in the field, we always ended, and someday this is going to help people with anxiety disorders and trauma. And then I kind of thought, but does it? I don't actually know.
Okay.
Like that translation. Right. So at this time, there wasn't really translational science happening and we were kind of operating in silos.
Okay.
And so I kind of felt silly or almost an imposter saying that this is going to help patients. And
you're like, how?
Yeah, how? So that realization pushed me to human neuroscience.
Okay.
That brought me to a postdoc at the University of Michigan with Luan Fan. And that was my first introduction to working with patients with post-traumatic stress disorder at the VA hospital in Ann Arbor with veterans, and then also with just community trauma as well.
Right.
And so I learned so much about human research and clinical trials. And I learned that you can't order people from a supplier and house them, in your lab, right? So I was a bit steep learning curve.
Right.
But what interested me then in Wayne State, when I was kind of looking for other opportunities, was the Detroit community.
Right.
And when I looked at Wayne State, there was some amazing research happening, but there was a gap in post-traumatic stress disorder research.
Okay.
There are people that work on it, but there was nobody doing like the neuroscience of it that I was doing. And so I thought this is a perfect opportunity for me to bring the research I'm doing to the city of Detroit.
Right.
And that was really the motivator. When I came here, it just was very clear to me immediately that this was the environment and the place and the community I wanted to work with.
Right.
And the community needed these services.
So it was kind of like a perfect match at the time. There was a need. You were ready to be that need. And
yes.
So that's great. So thinking about your time here, obviously you've done a lot of research in a lot of different areas. What would you say right now are some of kind of the emerging priorities across the college regarding research in this area?
Sure. So what's really great about our college, being College of Pharmacy and Health Sciences, is that we have a lot of different health professions under one roof, right? And so we've got a lot of research that's happening in the college. And you mentioned a little bit about it in your introduction. So we've got the antimicrobial resistance, brain health, chronic disease management. And so these areas that our college work in are some of the biggest health challenges of our time. So antimicrobial resistance is a growing global threat, right? As bacteria become resistant to existing treatments, brain health is increasingly important with an aging population and rising rates of mental health. Chronic diseases like diabetes and cardiovascular disease continue to affect millions of people and strain the healthcare system. And so addressing problems of this scale requires collaboration. It requires diversity in the people that you bring to the table.
Right.
to accomplish these goals and these research projects. And our college is well positioned for that because we bring together scientists, clinicians, pharmacists, therapists, public health professionals, right, who are all working on different pieces of the same puzzle.
So then, how would you say that these priorities are translating into progress that people can actually see in a way that impacts their lives? Because I think one of the challenges we often face when talking about science is that for people who aren't embedded in the field, it can feel overwhelming, a little daunting to try to really understand. So, I guess what are some of the ways that people can see this impact maybe in their communities, in the health systems that they are within, whether they're receiving primary care or specialists? Like, what are some of the things that, like, direct correlation?
Yeah, absolutely. So our college sits at this intersection of discovery and care,
Yeah.
right? So our scientists are developing new therapies, and our clinicians and community researchers are figuring out how those therapies can meaningfully improve people's lives. So a lot of our faculty are embedded in the hospitals, clinics, community organizations. And the questions they work on come from real world challenges. They come from what they're seeing in the clinic, what they're seeing in the hospital. And so as a result, what happens in our labs and clinical studies often feeds directly back into practice, whether it's proving how medications are used, advancing treatments for infections, helping people recover mobility after injury, or increasing access to mental health care. We have several clinics associated with our college that are, some are student run, that provide care for the community, but that also isn't just care for the community, it's also informing how we care for the community. In your previous episode, you had Christine Kevlin on, and she is the Stella Lab. It's a research lab, but it's also a mental health resource currently for our students. And so I think the fact that we have people embedded across the continuum of translation is really a strength of the college.
Right. And, you just mentioned Christine's lab. You talked about the antimicrobial resistance. The college just recently received a grant for that, as well as a award for the lab. How does that impact the way that you look at the work and the impact that we're making as a college? The fact that there's all these universities vying for the same resources, and the fact that we're able to continue to get these resources, how does that reflect on the research? How does that reflect on the people? And what do you feel is the long-term impact by that research being done here in Detroit versus other areas of the country?
Yeah, well, I think those examples of these achievements and these grants that our faculty are receiving is just evidence of the impact we are having. These are competitive, these are difficult to get. And it's just showing the impact we're having. It's not just that our science is within that project alone, but that we are making links to future projects, as well as how this could be used to impact healthcare and changes in healthcare.
So, Christine, kind of zooming out a little bit here, let's talk a little bit about some of the main high-level priorities of the college right now, and things that are happening, not even just specifically to your work, but just at a broader scale, and how that's impacting the health sciences.
Sure. So, like I said, one of the things that makes our college so unique is the sheer breadth of the health research that's happening here. Our faculty are working across a full spectrum of health, from basic science discovery to clinical care to community engaged research. We've got strong programs in neuroscience and mental health, cardiovascular and metabolic disease, infectious diseases, and pharmacology drug development. And these groups are working on everything from understanding disease mechanisms to generating therapies of our future. But we're also home to exceptional rehabilitation science research. Our occupational and physical therapy faculty are advancing new approaches to improve mobility, recovery, quality of life for people living with injury, disability, or chronic illness. And we have faculty studying how healthcare is delivered through health systems research, population health, public health. And going kind of tied with that, another unique strength is our research on teaching and learning in the health profession,
Right.
and interdisciplinary teams. And so this helps us improve how we train the next generation of healthcare providers. And so what ties all of this together is the translational focus, taking discoveries from the lab and moving them into better care and healthy community.
When I think about healthcare, health science research, I think that the overarching theme is we're looking to solve health problems and health challenges. And, those are two words that are ultimately correlated with kind of negative things. You're not looking to research something where there isn't a problem. So from a positive standpoint, what do you feel the most encouraged about, and what gives you the most hope for the work that is being done now and where we're going in the future, where you can say, these are challenges we're facing, but I feel confident that down the road we may solve this, or we will solve this, or I see things that are happening that are different now than they were even 5-10 years ago that make me feel excited about the future of research and solving some of these health crises that we face as a country and a world?
Yeah, so that's a wonderful question. What I think some of the major things I'm seeing, for instance, in mental health, acceptance of mental health condition,
Right.
not viewing a mental health condition as a weakness. It's a condition just like any other
Right.
condition that somebody might have, or disease,
Yeah.
right? It's just might be invisible.
Yeah.
So that acceptance, and with acceptance comes development of more resources for people getting the help and services that they need, which then also reduces strain on the healthcare system.
Right.
Another major, I would say, change or shift in the landscape is this personalized, individualized medicine. So not treating, everybody as your disease state. No, you're an individual.
Yeah. It's not one size fits all.
Exactly.
Yeah.
You're an individual with this disease state.
Yeah.
Right? We don't say a diabetic person, we say a person with diabetes. Right? And so recognizing that, and when we have that perspective to appreciate that these are individuals with very different, backgrounds, histories, biology, then that also forces us to think outside the box.
Right.
And think about, okay, we need to stop coming up with solutions that we think are going to treat the disease state, but how do we treat the individual? And so that's where really exciting work comes in pharmacogenomics, right? Picking treatment strategies based off of someone's genetics.
Yeah.
Which is so fascinating to me.
And compared to, I think, a lot of other research, that's still, and correct me if I'm wrong, kind of in its infancy stage. It's just something that we're starting to realize, that how do we use our own genetics? How can we use our own immune system to fight illnesses that we used to treat with medicine? Just fitting that blanket one size fits all. You have this, here's your medicine, and we'll see you in X amount of weeks. I think that individualized care that you're talking about is helpful from a health standpoint, a physical health, but I think the mental health side too, we've talked about that throughout this episode. Being treated like a person and not like a disease is night and day how people respond to things too. If you have that sense of this doctor wants the best for me and is giving me a treatment that works for me, not just kind of like here's another patient that I have to treat. Right. And that, I think that changes your mental health in that regard and how you approach this. So I'm excited to hear that you're excited about that, because that's one of the things that throughout the history of medicine, you look of how people have been treated. And sometimes when you deal with pandemics and things like that, you have to kind of treat things that way. But if you have the time, the resources, the opportunity, I think it's so important that we make that shift.
Yeah. And even if you're in a situation like a pandemic where time is of the essence and resources might be limited or non-existent, when you're developing things on the fly, coming into that with that mind frame is just as important. Also, I think a lot of thinking about personalized medicine has also improved outcomes for patients and their quality of life,
right?
Especially in things with like terminal diseases, so terminal cancer, right? The way we treat it or approach it, people are surviving cancers that they wouldn't have survived,
Yeah.
years ago, right? There's a lot of different things, or the treatments that they would have received years ago would leave them with long lasting effects
Right.
and impairments
Right.
that aren't a thing.
Yeah.
They're a thing of the past.
Right.
Which is just amazing and fascinating to see.
Yeah, it's great that we're getting to a point where we're reading about it in journals and textbooks, and you're not always seeing it firsthand anymore. So that's great on that progress. We are almost out of time. Is there anything else top of mind that we haven't covered that you'd like to discuss?
I think just kind of one of the last things I'd like to say is that for me, I do clinical research. I work with human participants, and I can't tell you how grateful I am for the individuals that participate in the research that we do, that I do, that participate in any of the research, because they're putting their trust in us.
Right.
They're trusting us. In my case, they're trusting us with a trauma, something very deeply personal and sensitive to a stranger. And that right there is such a huge impact. And so I just want to say I appreciate the people that engage in the clinical trials, that trust us with that. And I just want to thank them.
Yeah. All right. Well, we're out of time. Christine, thank you so much again for joining me. I always feel like whenever we get a chance to talk, I always walk away with learning something. So I appreciate that. Also, for anybody who follows us on social media, you'll often see that we repost a lot of what Christine posts. I've said it before, she's like a rock star of our social media because she just does such a great job of sharing information and getting it out there. So if you aren't following us, follow the link in the show notes and you can see more of the work that Christine's doing. We'll also put some other links to some of the work that's happening across the college. So Christine, thank you again.
Thank you, Mike. I had so much fun.
All right. Again, if you'd like to learn more, check out the show notes for links and additional information about Applebaum research. Until next time, I'm Mike Morland, and this is Where Health Happens.